Greetings. Good to see everybody again today. Welcome to our 47th Town Hall series. You know, it's that time of year when we're just hoping for some cooler weather. I guess it's been slightly cooler in the morning, so a really great time to talk about nature and our ability to get back outside and really benefit from being outside and the effects of nature on healing. So we'll be doing that with Dr. Sadir Al-Kindi today, and very much looking forward to that. We'll also, tying in with that, be talking about preventing cardiovascular disease. Both of my colleagues here, we were joking before the beginning, before we started, that their job is to keep all the rest of their colleagues out of business in preventing cardiovascular disease, and I'm all for that. On the live stream, or in the live chat today, we have Dr. Mohammed Taha, one of our fellows, so he is there to help with any questions you might have, and as always, you can text your questions with the word DeBakey to 37607, or you can go in the text box right there on the stream. So we're going to start with Dr. Al-Kindi. Tell us a little bit about, I know we all feel the benefits of outside, but you can actually give us some data and back up some of that.
Well, thank you for the invitation, and we'll talk about something that is really not, we don't talk about it as often in medicine, unfortunately, but hopefully, through this conversation, we'll bring it to the attention of individuals and people. So I'm a cardiologist by training, and, a lot of my talk is going to be around cardiovascular and cardiometabolic health, but a lot of the slides can actually be applied, and the science can be applied to multiple health diseases. So cardiovascular, in the modern world, cardiovascular disease, if you look at the figure on the right side of the screen, you see that we've been focused so much on the heart and looking at the heart and the arteries of the heart and the muscle in the heart and so on and so forth. And then, as time goes by in the 80s and 90s, we started recognizing that there are risk factors, and these are risk factors for heart disease, including smoking. You need to sleep well, you need to eat well, you need to exercise. But I would go a step further and think about the environment that we live in and how we interact with that environment as a determinant of health. So the impact of lifestyle factors, diet, physical activity, and stress, and also how do we interact with our environment sometimes is more determinant of your risk, whether it's cardiovascular risk or cancer risk, beyond genetics. And it can contribute to your health more than you think. So there's a growing interest in the role of natural environment in understanding cardiovascular and cardiometabolic health. And we always go back to this question of nature versus nurture. And hopefully by the end of this talk, we'll convince you that nature is as important as nurture, and probably even more. So biophilia is a term that people use, and it comes from bio, nature, and philia, where we like nature, love nature. And there is basically innate connection of humans with the nature, and we possess this deep-seated affinity to interact with the natural world, and suggest that our evolutionary history really primed us to find nature exciting and restorative. We also are connected to nature by design. So if you look at, not necessarily just the natural environment, but how we make our environments more natural or natural looking. And this can happen across scales, as you can see on the right side, whether it's scales of time, where hourly, weekly, monthly, and annual, throughout the life cycle, but also across geographic scales. So, your neighborhood, even your home, your living room, but also going beyond that to your national area, your county, or your census tract neighborhood, and then internationally, obviously. So these natural materials and spaces, they use organic materials to make us feel connected to the environment around us, and this is really leading to more sustainable health and leading to what we call primordial prevention of heart disease, which is even before we prevent heart disease, we prevent the risk factors of heart disease and other diseases. So science has backed up the notion that nature is connected to health directly, and you can see that green space is one of the kind of markers of connection to nature. And we have a lot of environmental effects from green space. We have a lot of social effects of green space in parks, and we have a lot of human effects. So some of these important environmental effects obviously is oxygen production, filtration of air. Also there is this concept of shading and reducing urban heat islands and blocking light, which may be harmful sometimes, and so on and so forth, and carbon sequestration. And the social effects, if you go to parks, there is increased social interactions, there is reduced crime, there is usually lower energy consumption, and allow you to interact with other human beings so that you can improve your health. And then human effects, obviously, when we do these environmental and social interactions, then we get to lower risk of heart disease, lower risk. Studies have shown that there is lower risk of mortality, death from heart disease, and other cardiovascular and other non-cardiovascular diseases, lower risk of hospital admissions, better mental health, less stress, lower blood pressure, and so on and so forth. So this is all backed up by science, and I'll show you a few of the studies in the coming slides. So the question becomes is how does nature really protect health, and what are some of the interactions? So the major kind of drivers, I would say, there is reduced stress and increased connectivity with other individuals and feeling the sense of belonging to a bigger purpose. There's also improved physical activity. If you are spending more time in nature, you're more likely to improve your walking and running and biking and so on and so forth, and better air quality. Air quality is a major issue and something that we can't really control for the most part. So being in nature, being in parks and connected to the nature can help reduce that or improve health effects from poor air quality. So this is a study that really compiled all the evidence that we have. It's about 53 studies from 18 countries looking at more than 100 million individuals. And it showed clearly that the more green space around the area that you live in, the less risk of death from ischemic heart disease, so that's heart attack, strokes, cardiovascular death, stroke death, and stroke prevalence as well, so that the stroke events that happen, and then also cerebrovascular disease, which is risk of death from stroke and related conditions. And these studies suggest that urban design that promotes access to nature, having more parks, having more green spaces, having more protected kind of areas for playing and interacting and so on and so forth, can actually improve population level heart health. We have studied this and looking at another aspect of nature, which is a metric called walkability, and how walkable your neighborhood is. And it's a measure that we look at with respect to how safe the area is, but how often do people walk, and how green the area is, and so on and so forth. So it's a measure of walkability. And we showed that across the nation, in 70,000 neighborhoods, there is as you can see on the right side, the more walkable the neighborhood that individuals live in, the less risk of elevated blood pressure, the less risk of elevated cholesterol, the less risk of obesity, as Dr. Avenatti is going to talk to us about, and less risk of diabetes and coronary artery disease, which is a major determinant of cardiovascular health. We have been also studying the impact of green space, and it turns out that not all green space is created equal. We have been using technologies at Houston Methodist that really AI, advanced technology, using computer vision. We take these images across Houston where we look at these Google Street View images, and we look at the separation between vertical green space and horizontal green space, and think about it as trees versus grass. And what makes sense to us is that the trees have more impact on green space that's vertical, has a more strong association with less risk of heart disease and less risk of stroke as compared with horizontal space. So that's something that is emerging, and hopefully we'll have more data about that. So what can we do to improve nature access? What can we do to improve our health through nature interventions? It turns out that even brief encounters with nature, sometimes 10-minute walk, 5-minute walks, 20-minute walks, can have a profound impact on stress levels. It can have a profound impact on the areas in the brain that are stressed and kind of fight or flight response, and you can see different signals when people walk in the nature before and after. Even houseplants, things that are micro in your microenvironment at home. So houseplants, giving window views. Some of the things that we're trying is really, even in the hospital, providing some virtual windows in areas where we don't have windows, and providing access to nature in that regard. And all of these have profound impact. And you can see on the right side some of these interventions that can be attempted at different scales. But really, it doesn't have to be super complicated. Of course, greening the neighborhood, greening the city requires a lot of resources, and that's been happening in Houston. But even at your own microenvironment, you can have significant impact on your health through interventions of nature. Some things that we're trying in the hospital as well, on the hospital side and from the clinic side, is really outdoor prescriptions. This is a work that's led by my colleague, Dr. Marc, that is working on providing and understanding the impact of providing outdoor park prescription, outdoor nature prescription to patients, and see the impact on cardiovascular health, and see the impact on mental health, seeing the impact on different type of conditions and diseases. And we know that connection between outdoors and social engagement can have a significant reduction of loneliness, and that by itself can have an impact on multiple domains of health. So I'll show you a few slides on a few data that we've been able to compile and put together in terms of projects that looks at Houston, so the local area. This is a study that we've done looking at the greenways bayous, and as you know, these greenways that were created in neighborhoods to connect the bayous, so we can have a lot of walkways, vacations, and things like that. So that speaks volumes to the effects of the neighborhood and your walkability and the nature access on cardiovascular health and beyond. We looked at thousands and thousands of patients that get care at the Houston Methodist. This is a study that we looked at about 220,000 individuals who have cancer history from Houston Methodist between 2016 and 2022. And we looked at whether they reside in a walkable area or they reside in non-walkable areas. And you can see that residing in higher walkability neighborhoods was linked to 21% reduction in high blood pressure, 33% reduction in diabetes, obesity, and any cardiovascular risk factors. So that adds to the pre-existing literature to suggest that nature access, walkable neighborhoods, can have a profound impact. And it turns out that it's not only the nature access, but there is an interaction. On the right side, you can see this is an ongoing study where we're looking at the interaction between neighborhood walkability and nature availability. So it turns out that in the green here, you see significant reduction when you have of cardiovascular risk when you have higher walkable neighborhoods that reside in higher nature areas. So that's something that can really interact, and how do the various aspects and domains of your neighborhood interact with each other to produce cardiovascular health. This is other type of work that we're doing, and we're kind of in science, we're taking a step back and saying, okay, let's look at things in unbiased fashion, because there's more things that we don't understand than things that we do understand. So this is work where we take images from satellite images, work where we take images from Google Street View images, and then we link it with cardiometabolic and chronic kidney disease and obesity and diabetes at the neighborhood level. And we wanted to ask, using AI technologies, evolving AI technologies, we wanted to ask a simple question. To what degree does the variance between neighborhood to neighborhood in terms of stroke prevalence or coronary heart disease prevalence can be explained by things that we can find in our neighborhoods and environment, and what things are actually associated with these risks? So what we find is, in these images here, we find that, first of all, about 60 to 65% of the variance between neighborhood to neighborhood can be explained by things that the computer sees on these images. And it turns out these are actually green space. So a lot of the green space that is being picked up in these heat maps in the lower part of the screen can be associated with lower risk of coronary disease, stroke, and chronic kidney disease. And you can see on the right side this correlation between what we can predict using these images, but also what we can observe using data. And there's a strong correlation. So what are we doing at Center of Health and Nature? We are doing a lot of different projects. We're looking into how can we improve heart health from a nature perspective. So we are partnering with companies that have really high resolution aerial imaging around Houston to quantify nature. And this can be quantified over time. So we can track the individual over time. How does that improvement in nature access, how is the improvement in tree planting and so on and so forth can actually enhance health, and look at the trajectories of health. We are also looking at, there is a Greening of Houston initiative, and we're looking at what is before and after, what is happening in terms of health outcomes, so that we can produce the evidence that can, push our policymakers, clinicians, and so on and so forth to adopt nature access as an intervention. We're looking at very kind of sophisticated high spectral images that are obtained from satellites to look at the quality of green space. We're looking at nature and how do these link together across seasons, and how do they link with cardiovascular health. We are also partnering with other kind of groups to look at the impact of apps on the phones or wearables to look at cardiovascular health and other non-cardiovascular health to investigate where people spend most of their time and how much time, so the nature dose, so to speak. We're also investigating, like I mentioned, the Parc prescription and how can it integrate in different service lines and things like that. And of course, we cannot forget about nature and health equity, and that's a big major issue that we're trying to tackle, to understand really to what degree does nature inequities contribute to health disparities, and how can we bridge that divide by producing maybe, for example, targeted Parc prescription or nature prescription. So I'll stop here, and thank you so much for listening in.
Wow, I've got so many questions, but it's fascinating. And but I want to get to Dr. Avenatti first, and then we're going to have some chance to ask both of you a lot of questions. So let's turn to you and talk about cardiovascular disease prevention.
Well, that's very high stake to follow, but thank you for having me here today and share with you what we do in the cardiovascular disease prevention and wellness division within Methodist. You've heard by Dr. Al-Kindi, there's a lot of research ongoing in areas that were not considered traditionally to be cardiovascular disease prevention. And we really strive to get to the most of our patient in terms of clinical research and education. And it really takes a team. We're part of a bigger team that really wants to get to our patient in the best way possible, trying to tackle all different aspects of cardiovascular disease prevention. And it takes a team because cardiovascular prevention really changed over the course of the last couple of decades, from being really focused on a couple of things like cholesterol and high blood pressure with honestly minimal tools that we could deploy, to a field that's fascinating in ways in which we see now the interaction between diseases that were considered to be very much separate, now really interacting in the single patient. And now we're fortunate enough to have a lot of new tools to which we can use to address all of that. We see that in our single patient, and we see that as a general push from our scientific society. This is the latest statement from the AHA that really called for cardiovascular prevention to move past what was traditional kind of siloed care and look at the patient in an holistic way, in which we really need to strive to prevent and manage obesity, type 2 diabetes, and CKD, so chronic kidney disease, is a single entity in the single person we have in front of us. And so in our clinic, in our approach is really to put all of that science back to the patient level and to tailor our intervention to the single person we have in front of us. And we do that through individualized risk assessment, through biomarkers and physical assessment and imaging and genetics if that's needed, and then really trying to tackle every single piece of that puzzle. That's the health of the patient we have in front of us. And now, I really want to spend the next few minutes on one of the aspects that has kind of been overlooked for a very long time, and that is obesity. We've heard that obesity is linked to cardiovascular disease, but what we realized dealing with our patient and taking care of our patient was that we were really letting them down as far as obesity management. And this has become evident in the last couple of decades. These are two maps of the United States, and you interpret this as heat map. So basically, the darker the color, the bigger the problem. And on your left-hand side, you have 2011. And there's some green, there's some yellow. Green means that less than 20% of individuals living in those areas reported themselves as having obesity, so a BMI that's higher than 30. And then over the course of 9 years, you see that map kind of catching fire. Dark red is more than 50% of the population dealing with obesity in 2020. And the projections are even more dire. We're looking at 50% of the population of the United States, adult population, living with obesity by 2030, and 25% of all adults in the United States living with severe obesity, which is a BMI more than 40. So it's like we have to do something. And why did we take that on us, upon us as cardiovascular prevention physicians? Because obesity is strictly linked to all of the things we're trying to prevent or treat in our patient. same type of map. On the top is ASCVD, so that is your stroke, your heart attacks, your peripheral arterial disease in 2020, and then is heart failure just below that, and then on your right-hand side in the blue is type 2 diabetes. And as you see, the darker areas are exactly the same in all of these maps. This is kind of a testament of how all of this strictly interacts. And there's many, many reasons for this. We really don't have time to dive into this. But this was a recognition that we couldn't ignore obesity any longer. And the other thing that has happened in the last 11 years is that obesity has actually been recognized as a disease on its own. So if there's one thing you take away from this conversation today is obesity is not something that your patient is failing to take care of. It's not a lack of willpower. It's not something they're doing too much of. Obesity is a chronic disease and needs to be taken seriously and addressed exactly like we take seriously and address other chronic diseases. This, though, calls for a shift in the way we approach obesity and our patient. So just a couple of ideas on how the knowledge about obesity has changed. We mentioned that obesity is multifactorial. There are many, many more aspects that we could potentially discuss, and we already talked about the impact of the environment on the development and then maintenance of obesity. But I want to kind of walk you through what the current understanding is of the mechanism behind obesity. And this is kind of the theory behind it all. Our body defends our fat mass. This is called the set point theory, and it's postulated that basically in your brain there is a thermostat that regulates your weight. Exactly like you set a thermostat for your temperature in any room. And so a strict interaction between your brain and your fat mass set point, or the amount of fat that's in your body. And that it's strictly regulated because it was functional to our survival during evolution. So anytime your fat mass changes, let's say you gain weight, that kicks into a series of signaling to your brain that tells to your brain, hey, we got some fat on board. And then the brain starts a series of counterbalance mechanisms, such as reduction of your appetite, so that the fat mass goes back to its original point. On the other hand, you start losing weight, let's say you're on a diet or you get sick and you lose some weight, the same signaling go to your brain, and your brain kicks into a series of opposite kind of signals so that the fat mass gets back to where it was. This has saved humanity through millennia from starvation and famine. But what happens when we now kind of overimpose our current environment into that system? Our current environment is considered obesogenic. Think about sedentary jobs, sitting at your desk, using the car to move everywhere, not having time or space to go around and walk, and a diet that's not what our body was developed to deal with. When that happens, our system gets kind of overwhelmed. The fat mass set point gets moved to a higher level, and so we have an inappropriate regulation of our body our body fat mass. So all of this to say that what we need to do to tackle obesity is re-regulate that physiology. There's many ways we could potentially do that. We could potentially work on our environment, for example, and kind of make it less obesogenic. But from a medical standpoint, what we finally had the chance to do in the more recent year was finally have some sort of pharmacotherapy, some sort of medication that actually tackles that specific aspect. And so this is kind of the pyramid that we refer to when we talk about strategies to manage obesity. And at the baseline is lifestyle intervention and lifestyle modification. It should be the starting point for everybody. But then the exciting news and the thing that everybody has heard about, because you cannot live in the States without having a commercial thrown at you, is the newer medication. These medications work because they act on that interaction between your body and your brain, and in the re-regulation of the fat mass set point. What's exciting from a cardiovascular standpoint is that the same medication act on so many other aspects and so many other systems that they're actually able to reduce your risk of having another heart attack if you ever had one. They protect your kidneys from the development of chronic kidney disease. So it's really exciting, and that's why they're so popular at this time. So in the cardiometabolic and obesity clinic, we try to bring all this back to our patient. As I mentioned, very specific patient-tailored personalized assessment, and then counseling on lifestyle changes and support in the medication track, and if they need, bariatric surgery referral. The other thing that we do is really trying to push, as I mentioned, the clinical research and the clinical collaboration. So making sure that we don't keep that in our single department, but we spread that out within our system. So for example, we start a collaboration with our rheumatology clinic to make sure that those high-risk patients get screened and treated appropriately. We have a collaboration with our heart failure team to kind of help with the pre-transplant and post-transplant, making sure that those other risk factors are actually taken care of. And then this is my mission as of today, making sure that that science gets transmitted to our fellow providers, because obesity as a disease is not recognized. And so what breaks my heart is having my patient tell me, my doctors always told me, come back when you've lost some weight. We're not helping them in that very, very difficult endeavor. So I kind of sneak myself into every single conference at Methodist that I could over the last year. And the other thing is I am trying to build a program for the new generation, kind of training current trainees, both at the fellow and resident level. And I was fortunate enough to have the academic institute kind of support that endeavor. So I hope that I'm gonna come back and give you updates on this education track. The idea is we should stop treating obesity as a fault on our patient and really start tackling that as a disease. Thank you.
Well, thank you, Dr. Avenatti. Thank you both. Fascinating. I was telling them before, oftentimes when we do some of the really technical talks, I often bring it back to some of the primary care and say, how do we not end up having to have that procedure? We're there when you need it, right? But that's really what you two do day in, day out, working with our patients. So thank you. I have more questions than I can count as a primary care physician. Let me start with you, Dr. Avenatti. So somebody's watching here and let's just pick something. They're 50 years old and they say, I want to live really, really healthy. I've got some heart disease running in my family, et cetera, et cetera. They come see you. What's that workup look like? And what's that look like for them if you're talking about how are we going to keep you healthy? How are we going to avoid all of this cardiovascular disease? What does that look like in terms of the testing you do, the things you discuss with them?
Right. It looks like a very long conversation.
I'm sure it's not a quick, short one, right? So.
And it really has to do with merging what they need and what we can offer, and knowing that everything in medicine is kind of risk-benefit balance. But what it looks like is a detailed history, a family history and a personal history, and a detailed understanding of where they're at as far as physical activity as well as stress levels and all those things that we don't consider necessarily being risk factor for cardiovascular disease, but they are, including sleep deprivation. And then it's a set of labs. We're looking at the classic things like cholesterol, but we also look at inflammatory marker, CRP. We look at the kidney function in details. So I'm usually I'm throwing in a urine test for them and proteinuria. And then we usually do a calcium score. Mm-hmm. And that's gonna
explain what that is for everybody.
Yeah, sorry. So a calcium score is a CT scan that's low radiation. It's the same amount of radiation that you get through a mammogram, basically. So super safe within our system because we have great technology that allows you to do that with no contrast. And what we're looking at is basically calcification inside your coronary arteries. And that is a sign that the disease process, so the atherosclerosis that's kind of underlying the cardiovascular disease we're wanting to treat, has started. And so that helps me kind of gauge how aggressive I need to be. Because for some patient, honestly, consultation and some kind of nudging in the right direction as far as dietary patterns and physical activity and control of things like stress and better sleep patterns might be more than enough. For other patients, we might need to talk medication, and that I want to have that knowledge to be able to provide my best recommendation regarding the strength of the medication, the amount of medication we need to take, and whether we need to shoot for a certain level on blood test as a marker, or we could just say, you can take it, we don't need to check on this anymore. And then most likely, if they have concern for high blood pressure or family history of cardiac disease, I would probably throw in an echocardiogram as well and a Doppler of their arteries.
So what are you looking for in the echocardiogram? That's an ultrasound of their heart.
Ultrasound basically. Of the heart. What we're looking for is structural changes that might have been induced by a high blood pressure that was going undetected for a long time. And the good thing is that if that is the case, we can walk them back, so it's reversible. But the sooner we know, the better we can tackle that.
So the calcium score, it's a score, literally
it's a score. It's a number.
So it's a number. You'd like to have 0. That means they're
Yes.
in there. But of course, it can go up very high, and I know it changes with age, and how likely you are to have an abnormal test. At what point do you get way more aggressive with people on a calcium score? Like if somebody does come to see you?
Oh, tricky question.
Yeah.
But I like it. So way more aggressive on my personal is above 300 to 400.
Okay.
And that has to be adjusted for age, of course, because if somebody
So you're seeing a very significant calcium score before you get not more of a, hey, I see just a trace here.
So again, it depends how aggressive the patient wants me to be.
Okay.
But if somebody is 40 and has a calcium score of 10, to me that's early disease.
Right. Because at that age, most people
shouldn't have that.
Right,
but in the most of our data says that when it gets to 300 to 400, you have the same risk of somebody who had an event. So that's what I'm meaning by very aggressive.
So you get to that kind of score, it's as if you've already had a heart attack or already had a stroke or something that would cause you to get.
So what I tell my patient is, I'm throwing the kitchen sink at you. Before that, it's a lot more nuanced conversation, and it's a lot more what the patient wants and what the patient needs and what I can offer. And we go by numbers. Your risk is X. If we do this, we can reduce the risk by 30%. Now that 30% might not be significant to me, but I'm not who's making the decision, right? It might be significant for you. Going down 30% from 10 to 6 might be very significant for you. Mm-hmm. And I'm going to support you.
Some others may not, right?
Exactly. Yeah. For somebody, might not. I have a patient who was like, I'm 75, I'm doing great, I'm taking no medication. Do I really need to be on a statin? I was like, ma'am, your risk is 15, it's going to go down to 10. Mm-hmm. Do you think that 5% is going to make your life different? Do you really want to? And she was like, no, I'd rather not be on medication. And that's okay, as long as you have a reasonable conversation, an open conversation.
Make an informed decision.
Exactly. Right. I think prevention is a lot about shared decision making. Because honestly, we're asking people who feel completely fine to get on board with 1, 2, 3, 5 medication. Mm-hmm. It's hard. If you don't know what you're doing and why, and it's not relevant to you, they're really not going to buy onto it. And that's okay.
Great. Well, thank you. That's really interesting. I got a lot of questions about nature and health too. So, I mean, okay. So let me start with putting my hospital CEO hat on here. We've talked about sleep here before, and I've often talked about how we're working with a technology, a bio button, to try and get people better sleep in the hospital. Because one of the ironies is, right, sleep is so important. You mentioned
and we don't get it,
and we don't get it when you're the sickest in the hospital. So you've just told me nature's really, really important, and we're sticking you in a high-rise building in the middle of the med center. There's very little green space we could even access. Is there something we could do about that? And I guess part of my question, because we can't really magically wave a wand and put a bunch of trees, right in your room. But are there virtual approaches we could use, or other things like that? Is it the same if I get sort of a virtual exposure to nature versus I'm physically out there, for example? So tell me a little bit more about how we handle that on an inpatient basis.
Thank you. So this is great. I mean, I think it's just not only good for patients, but also for staff, right? I mean, that's also a big problem.
Very good point.
When I experience this on a daily basis.
Good point.
But you're exactly right. I think, focusing on getting better sleep is very, very important. But it might be something that's also related to the microenvironment that you have in the room, whether it's staff room, whether it's in the nursing station as well. And then how do we actually have that healing, specifically for people who have high levels of stress, which is literally almost everybody in the hospital, right? So I think there are approaches that some hospitals are taking, and I know that we have a healing garden that is something that's hopefully will get bigger over time, and we know that in the new tower we'll have some green space that's providing green space for patients and nature access, at least part.
What you're referencing is with our Centennial Tower, which is under construction. There's actually, I forget exactly which floor it's on, but there's basically an outdoor space that will be very green. We've worked with Texas A&M and others on that. We'll come back to that question. Right. But anyway, sorry to interrupt.
So some of the approaches, I think
the people watching wanted to make sure they understood the context.
So I think you're exactly right. So the issue is always priorities and also real estate, right? So in the rooms that are sometimes small for patients, where do you put plants? Do you put plants even, because some of them are, especially real plants, have issues with bugs and so on and so forth for immunocompromised patients. But I think there are some approaches that people are taking where virtual windows is becoming something that we're, hopefully we'll be testing soon in terms of health outcomes. So what virtual windows are is you have a screen similar to this, and instead of showing ads or menu of the food and things like that, simulate nature. And you can probably test that at home, where you can turn on your TV and turn on videos of people walking through nature, and that has a profound impact, I suspect, on health, at least in the short term. I think there is also simulated not only nature sights, but also nature not noise, but nature sounds that can be also placed in several areas in the hospital, where it really doesn't interfere too much with the workflow, doesn't interfere with patient care, but it can have that impact. And we don't fully know exactly whether this is as impactful or not, but we have recordings, for example, from people walking in nature, or just recording from nature that can be actually played.
And are there studies to support that, or that's the kind of thing we want to understand whether that helps?
Yeah, I think the field in general, there are studies, but we need more, right, to actually be convincing, because obviously the literature and the studies on anything environment is confound. There's a lot of confounds, right? And it's difficult to study. It's very difficult to study things other than, especially the impact might be small at the individual level, but may have a profound impact at the population. So you need good, large studies that are well designed. And I think there are some studies that looked at nature, simulated nature, whether it's sounds, whether it's videos, but we need more to study this. But it doesn't. What we know is it doesn't harm, right? Mm-hmm. So there's definitely it might have a significant health impact. It doesn't have harm, and that's something that we can think about a little bit more.
Well, you mentioned the word confound, yes. Which for those of us in medicine, that's basically when you do a study and there's some other factor you're not accounting for that's Correct. Really the reason you're seeing a result, which was one of the things running through my head as I was hearing you talk. For example, you start thinking about greenness in neighborhoods. Yeah. Right, people with more money tend to live on bigger lots with bigger houses, more green space, nicer yards, et cetera, et cetera. People with less are oftentimes very crowded. They may be in, multifamily homes, apartments, et cetera, very urban areas, sometimes very little green. Yeah. How do we figure that out? Because are we just having a marker for many, many other social determinants of health? Or are we having a true marker for, hey, you can get out and you can actually, benefit from the green? How do you correct for those kinds of things in a study?
No, I think it's like anything in science, right? We start with association studies, where these correlations that we can make with green space and health and so on and so forth. And when study after study after study shows the same thing, despite statistically controlling for individual risk factors and other environmental risk factors, then that gets us closer to what we call causality, because we know nature can cause, or whatever thing that we're studying, a factor, whether it's green space or nature, can actually be causal in development of cardiovascular disease. So now we have thousands and thousands of studies that looked at this, and they all show very similar things with very little heterogeneity. Now, the second thing is we start to do experimental studies, where similar to what we do with drugs is, how do we know that the drug is working? Because maybe the people who are taking the drug are also more affluent and so on and so forth. So we do the exact same thing, where we start to experiment on individuals, where we can have an individual take images of their brain, including PET scans, which show you areas of the brain that are highlighted or lighting up when there is stress, for example, and you walk them through a nature trail for maybe an hour and a half, and then you test them again. And then you see profound impact, because that gets us also closer to causality. And then eventually we'll do randomized trials, where people don't know, but these are difficult in the environment space, because the magnitude of effect may not be as large. And it's hard to blind individuals, patients, which is the gold standard in clinical studies, as you know, is really blinding the individual and the investigator to, is this a green space or no? So, these are probably going to be difficult to do, but I think we're getting closer to doing something similar to that.
So we live in Houston. We're as I said at the beginning, we're getting through the hot time of year where a lot of us try not to go outside. Of course, other parts of the country will do that in the winter. walking on a treadmill versus walking around in a neighborhood.
Yeah.
Is there studies to say is one better than the other?
Yeah, I think
Because that seems to me like that might actually support a hypothesis that says it's more than just the exercise.
Correct.
There's actually something about being outdoors and experiencing the sights and sounds and smells and everything else of being outdoors. Has anybody looked at that kind of data?
Yeah, I haven't come across a study that specifically answered this question, because partly is also how do you get that data, right? Like it has to be self-reported, and the accuracy of that is also limited. I don't know of any study that actually studied this specifically, but there are studies that looked at something similar where they compared physical activity during, in nature versus not nature, for example, and showed that nature or green space, physical activity during or in the location of green space can be significantly associated with lesser risk of X, Y, and Z health outcomes.
Great.
So, and these are large studies that looked at populations.
That's great. Well, thank you. So many things to ask and answer. I got a few more for you, but I want to make sure we're getting to things that have come through while we're here. I'm going to ask Dr. Avenatti a little bit. Someone asked, a lot of us have jobs where we sit at computers all day long. What do you recommend? Yeah, I mean, we all do, right? What do we recommend in terms of getting up and about and exercise? Are there data-driven strategies for people who are in more sedentary jobs like that?
So first off, the majority, again, of us are in a sedentary job nowadays. It's very, very rare that I run into a patient that has a very physically active job, but this is just the reality. We're immersed. Now, the data support 30 minutes of moderate intensity physical activity 5 days a week, which is kind of hard to put into that lifestyle, the 8-hour shift sitting at a desk. What we know, though, is that those 150 minutes don't need to be necessarily consecutive, so you don't have to exercise an hour. So you could squeeze in anywhere in your day.
Okay, so that's really, really important, right? Because, I mean,
yes,
a number of years back when I trained, we all thought it was, you got to do 30, 40 minutes each time.
No.
Now the data really says you can chop it up.
You can parcel that up. So if you have 5 minutes, if you have 10 minutes. And so what I tell my patient is the first step is try to walk some physical activity into your daily routine. And it sounds trivial, but it's effective. So park on the further end of the parking lot. Take the stairs if you have to move. And then if you are on a coffee break, go to the further coffee machine. And those seems very, very little changes. And there might not be enough for a lot of people, but it's a start. And then the other thing is everything we do that's new gets into the habit within our brain within 8 weeks. So it's going to be very hard for the first 8 weeks. If you can stick to that, it's going to get easier. And then the endorphins that are released by physical activity are going to kind of prompt you to continue doing that. So there's no really a recipe. It's very much personalized, whatever you can fit into your schedule.
So what's moderate? You said moderate was a
Yes.
key word you said in there. What's moderate? Because walking, I 100% agree with the advice that, hey, if you're barely doing anything, go now walk to the farther coffee machine. But that's not going to be moderate exercise.
Correct. That's not moderate exercise. When we see, when we recommend moderate physical activity, it's a physical activity that lets you talk but not sing. It's kind of a good way of
so
gauging that.
So you can be walking in the neighborhood with a friend and you're able to
You can have a conversation.
speak, but if for some unknown reason you decide to start singing to them,
Correct.
you'll be having trouble while you're walking.
Because you don't have enough energy for that.
Okay, so
you
your
don't
prescription is
have
everybody go out there and start singing to your friends. And if you can, you got to walk faster. Okay.
So again, those little movements during the day are not going to get you to that threshold, but it's a way to get moving.
Kind of gets you up there. Okay.
Yep.
And should you be clocking it? I mean, for that 150, is it? And you said over 30 minutes a day over 5 days. Is 150 minutes in one day okay? If it just is on Saturday, you're really active for the week?
It honestly is.
Okay.
And you can do your workout during the weekdays and then get the weekdays off, the weekends off, or you can
you can flip-flop if you want to do that. Okay.
Again, I think that the less prescriptive we are, the least resistance we're gonna find.
Got it.
The more people find that it
fits
can
with you.
be flexible.
But I love
with.
the advice of even just go out of your, not even go out of your way, just little tiny things. I'll go get the extra 50 steps every day that I go do this. It's even those little things are going to improve.
Because people will realize
activity
I can actually do this.
I mean, some days when I have a desk day, I get home and I do a step counter every day. I can't believe how few steps I have those days versus like days where I go around the hospital and things. Sometimes I've walked 2, 3, 4 miles just walking around the hospital some days. I didn't even realize. So, and I think it can make a huge impact. We got another question in about high disease neighborhoods. So, does this data for us on, disease rates and association what does it say about what we need to be doing in areas where we do see that?
Yeah, I think the issue is we are seeing that green space divide, right, or nature divide, which I personally think that this contributes significantly to the healthcare disparities that we observe in the hospital and beyond. And I think that's where we need to focus on nature equity or environmental equity, environmental justice for communities that really are impacted by high rates of cardiovascular disease and beyond health conditions. I think the key is really developing the evidence first, right, to show that this is actually, whether it's associations, whether it's interventions, whether it's X, Y, and Z, but then also working outside the hospital environment where we can intersect with policymakers, we can intersect and interact with people who can actually make that big difference in accessing and improving nature for communities that are important. The other thing which I didn't speak about is really how can we utilize nature access or the environment in our cardiovascular risk prediction and assessment, right? So in general, right now, patient comes to me, like Dr. Avenatti mentioned, we get blood pressure and so on and so forth, and we ask them. We often don't ask them about their environment as often. So getting that data, whether it's through questionnaires and things like that, or through geospatial models, similar to what I did, which really we have the address of the individual and we can tell about their neighborhood, can have a profound impact on how we classify that individual in terms of future risk. And perhaps sometimes is the intervention not only on improving their nature access, but by knowing that these individuals may not have the ability to be in nature, whether they live in a nature desert or so on and so forth, we can intervene on their regular risk factors by reducing their blood pressure a little bit more, by doing a little bit more for their cholesterol, because we know that these factors, environmental factors, act through the risk factors, the same risk factors that we study and investigate in the clinic. So, there are multiple avenues. I think as clinicians, we need to think a little bit more about how we can integrate these factors, whether it's pragmatically through their zip code and so on and so forth, or through actual measurement, and then how do we intervene upon them, but how do we integrate them into cardiovascular and other health assessment tools. And this is a lot of the work that we're actually doing right now.
So if I'm being a little skeptical, how do I know this isn't just exercise?
Yeah, and
right. I mean, as opposed to nature,
right?
If you follow the difference, right? I get it, because they're inextricably linked. You're more likely to walk if it's prettier and nicer, and you're outdoors and everything else, or if it's safe. All those things that happen. How do we tease that out and understand that? And I think of New York City, where any dense urban environment where people walk everywhere. They don't have cars, and they may get in the subway and things, but even there, they're walking blocks. So back to Dr. Avenatti's, hey, go to the Far coffee machine. Do we see health differences in people who live in an urban environment like that versus people who live in a semi-urban environment like a Houston, where you're in your car for almost everything?
Yeah, and I think on one side, does it really matter, right? Whether it's the green that you're seeing, or the shape of the leaf, or the sounds, or is it just becoming as part of an integrated thing, right? If you have nature, you're more likely to exercise and so on and so forth. So on one angle, as a pragmatist, it really doesn't make a difference to me, right? People who live in these areas, and we know we have evidence that people who move from one area to another that has more green space, they tend to exercise more, walk more, do things. So to a certain degree, whether the impact is direct impact through other mechanisms, through stress or through exercise or other things, from a practical approach, it may not make a lot of difference.
What makes a difference is create environments where people live, where they can do that safely and effectively and enjoyably and everything else.
That's very correct.
If I go out to the country though, and I go for a walk, or I go for a walk in my neighborhood, there's a difference. I mean, there's something about hearing the crickets and the birds and the frogs and the quiet and the breeze blowing and everything else. It's just not the same as when I'm in the middle of the city.
That's exactly right. And I mean, we feel it as individuals, but that has a profound impact on stress, which is a really major determinant of multiple diseases. I think most of the diseases can be linked back, including cancer, including obesity,
to stress management.
Exactly.
Stress, keeping those cortisol levels that you started one of your slides.
That's exactly right. And if you think about nature access and nature kind of prescriptions and so on and so forth as a way to reduce that stress, so be it, right? I mean, I think that's something that we can think about, and especially in neighborhoods in Houston where we don't have as much, green space as other places. We're lucky to have some, but not as good as other locations where we need to really invest our time and effort into improving this.
Well, thank you both. Really fascinating stuff. So I assume if people watching are saying, hey, I want to take control of my cardiovascular health, I want to prevent disease, I may have obesity issues, other things, they can schedule appointments with
Absolutely.
you or your colleagues. It's been an area
we have a big team.
We have a big team, and we've been really investing a lot in because it's so critically important. Well, thank you both for a very, very fascinating and illuminating topic. I hope everybody's enjoyed it a great deal. I'm going to, it's been a couple months since I've seen you all, and lots happened this summer, so I'm going to just give you a quick update on some things at Houston Methodist. First is an introduction, actually. Probably somebody a lot of you don't see that often is our Chief Financial Officer, but our current Chief Financial Officer, Kevin Burns, is retiring as of Monday, and just so grateful to Kevin for an amazing job he's done over the years. He's been here for about 12 plus years now, retiring, and he's going to straddle his time here and in Arizona, where he's from previously, has grandkids here in town. One of his sons is actually an amazing faculty member for us now, so I know we'll still see him. And we brought in now, actually started Monday, so they overlap for about a week, Anthony DeFurio as our new Chief Financial Officer. Anthony has 35 years experience in healthcare, probably about 25 as a CFO. Has been most recently an advocate before that in academic medicine at University of Colorado and University of Iowa. So we're just thrilled with Anthony joining the team here. That's occupied a lot of my time, obviously, over the last few months, finding the right person. He's so highly skilled, but he's also a great cultural fit for our institution. And that culture for us is so very, very important. We focus very, very purposefully on that culture. We did a really fun thing this summer with all of our employees, and each of them actually got this card that was actually a scratch-off card that went into the mail. Sorry, physicians weren't eligible, executives weren't eligible, but our all other employees got this and scratched off and found out they got a grossed up, so that the actual check is for $750 bonus. Just a great way to say thank you to our employees and appreciate everything they do. We were able to actually do this. We're going to do it towards the end of August, and then a little thing called Hurricane Beryl hit, and we said, people need money sooner, and so we were able to get it to people a couple weeks after Beryl, and so really helped a lot of people as well. And on that kind of topic of emergencies, this is something I'm very proud of. We actually surveyed our employees towards the beginning of the year around what are the benefits they really enjoy having. And one of the things that came through loud and clear, and we've seen this in studies everywhere, including in Houston with the Kinder Institute. And by the way, the Kinder Institute and the Kinder is big time in the green space and actually have helped support some of our programs, as well as obviously many, many projects here with our parks. But what we see with the Kinder Institute, what we saw in our own survey, is so many people, in fact, almost half of our employees saying, hey, if an emergency comes that I wasn't expecting, we can't afford it. And so we already had a program in place with Fidelity where there'd be a emergency savings fund. What we said to everybody is we'll start matching that. We've done that this year. We may increase that in the future, and we've been able to take it from less than 1,000 of our employees to now already over 5,000 of our employees who have this. And I think that hopefully will go a long way to helping people with that. And we have amazing long tenured individuals. We celebrated that last month. Here's just a few. I mean, we had 50, 51, 52, 53, 54, 55, and 57-year employees. And not to mention a whole bunch before that. And you see 4 of our 5 50-year there in the upper left. You see one of our 55-year employees, and then 2 57-year employees. I was joking with our board yesterday. They both leaned in for the picture. But I was saying they're so tired after 57 years, I'm holding them up there. And that's Essie Davis and Marguerite Spano. And, if you look at the jobs we've got in these group, we've got RNs, we've got surgical techs, we've got cath lab tech, we've got people monitoring some of our telemetry and other people with really awesome jobs who've given much of their lives to Houston Methodist, and we're so appreciative. And when you put those many good people together, all our amazing physicians, other clinicians, and really all the structure built around them and the teams of people, great things happen. And I've shown you these data before. This is actually Vizient, which is what I track the most as a balanced scorecard. Blue means we're in the top 10% of hospitals in our respective size groups. Green means next, or the top 25%, et cetera. 5-star means we were in the absolute top group. Second year in a row, 7 out of 7. There's no hospital system in the country that achieves this. Our academic hospital, HMH, Houston Methodist Hospital, in the medical center, highest it's ever been ranked, number 4 out of 115. Willowbrook in that next big group, number 2 out of something like 170 or so. And then we had the 1, 2, 3, and 4 slots. Last year we had 1, 2, 3, 4, 5, but Willowbrook moved into a different category. And so we are just doing beautifully well. And I'm proud of our teams for all they've accomplished with that. This is the group that was there celebrating. And let me tell you, people take notice when you see one institution doing that. With CMS, one hospital is 4-star, 6 of them are 5-star. I'm very proud of those performances as well. Then just a couple neat awards. I always talk about focus on the fundamentals. The awards follow, but it is fun to celebrate them when they come out. Forbes put us as the #1 employer in the state of Texas. Very proud of that. HEB number 3 here, a Houston brand as well that's often up there with us, and very excited about that with the team. Some awards around our virtual nursing and the digital effect that we have and implementation we have, which has been so popular with our patients, with our nurses, with really everybody, and you'll see us continuing to lean into much of that technology. And with one of the national nursing organizations got their #1 award. This is one institution a year gets this, really, for excellence in nursing care at Houston Methodist. Digital health, number 9 in the world, best smart hospitals. They started this 3 years ago. We've been, I think, 10, 11, and 9, so we're running there with all these different wonderful hospitals in the world. Then the last thing just shows picture of some things you will see coming. I don't have pictures today, and I had a question come in about the new building, the Centennial Tower. Centennial Tower will open in about 3 years, so it's going really, really significantly. We'll show you some pictures maybe next time. And of course, Cypress is opening up in about less than 6 months fully as a hospital. We've got some other activities already open there. But one of the things as we've continued to grow our physician organization is you will see us now creating pretty large comprehensive care centers, some as large as 100,000 square feet around the community, where you'll co-locate a lot of physicians, primary care physicians, preventive physicians, as well as specialty physicians. And depending on the site, you'll see physical therapy and lab and x-ray and CT and MRI and many other things at those sites, and quite possibly even some surgery centers and other things. So stay tuned. Thought you'd be interested to see the concept of that, and that will be rolling out over the next couple of years. With that, it's been wonderful seeing everybody. We will see you for our next session, and thank you as always for your support of Houston Methodist. God bless.